Cancer Day to the third and final CCAE Showcase Spotlight. Thank you for being here today as we welcome our final 4 civil society leaders to share how they are applying their learnings from the CCAE HPV vaccination learning series in their communities. My name is Meenu Anand. I serve as the Director of Global Cancer Prevention and Screening at the American Cancer Society. ACS co-chairs Cervical Cancer Action for Elimination with Cancer Research UK. Our collective goal through CCAE is to bring civil societies, organizations together to accelerate global progress towards a world free from cervical cancer. A quick housekeeping. Please share your name, organization, and country in the chat so we know who is in our audience today. You can use the chat or the Q&A box to add questions for presenters. We'll host a Q&A session with all presenters at the end of their presentations. And now let me request my colleague Leah to launch a poll so we get a quick snapshot of your experience in HPV vaccination. I'm going to be quiet for a minute as you get a chance to just respond to the poll. Thank you for your response. It seems like majority of folks are either somewhat involved or very involved in HPV vaccination. Looking forward to a very insightful and invigorating conversation today. Civil society organizations Sorry, I'm going to close these polls that are popping on my screen. Apologize. Civil society organizations globally play a critical role in advancing HPV vaccination and cervical cancer prevention, from community engagement to advocacy and implementation of effective interventions. The CCA Learning Series aim to strengthen the capacity of CSOs working in resource-constrained communities in low and middle-income countries with knowledge, skill, and tools to integrate insights from behavior science in their efforts to promote HPV vaccination as a key strategy for cervical cancer prevention. The learning series included, next slide please, a 4 days learning sprint in September with presentations by global experts and CCAE faculty, followed by 6 90-minute technical assistance sessions that ended in December. In total, the participants engaged in 19 hours of learning in a virtual classroom in a cohort setting, and many more hours applying what they learned in their communities. Today is the last of the 3 showcase webinars where participants are able to present their case studies. Over the 3 spotlight sessions, 13 organizations presented their findings. As the series wrapped up, everyone who participated and completed the full series put together a project plan and budget and was eligible to apply for a small grants and or seek funding to mobilize resources to implement the project that they had developed. The learning series cohort included 56 leaders representing 29 organizations from 17 countries with single shared goal, eliminate cervical cancer. The cohort was supported in their learning from international experts, including 8 experienced faculty members. The diverse participants in the series identified 7 types of target audience, 9 types of behavioral problems, designed 56 behavioral change solutions, and developed 14 evidence-informed projects. If you missed either of the last 2 weeks' showcase presentations, we will put the link to the recording in the chat, and I encourage you to take a listen. Some fascinating work that was presented and continues on. Today, you will hear from 4 cohort members from Nigeria, Ecuador, and Ghana. After the presentations, as I said again, we will have a Q&A panel with all the presenters. During the presentations, as the questions come to your mind, please put them in the chat or the Q&A box. And now, it is my privilege to introduce our first speaker of the session, Dr. Mariam Jamila Ali. Dr. Ali is a clinician scientist and Global Health Emerging Scholar Fellow with expertise in implementation science and global health equity. Dr. Ali leads HPV vaccination and cervical cancer prevention research among adolescents and women living with HIV in Nigeria. Her work focuses on translating evidence into equitable, context-appropriate cancer prevention strategies in low-resource setting. Over to you, Dr. Ali.
Hello, everyone. Greetings. Good morning, good afternoon, good evening from wherever we are joining. I'm glad to be here. Today, I will be presenting my topic that we worked on during the learning series. And we worked on leveraging on religious leaders to increase uptake of HPV vaccines in Nigeria. Next slide, please. So the main public health problem was that HPV vaccine uptake is below national target among girls 9 to 14 years in just specifically Nigeria. And this is likely to limit the WHO target for vaccination for cervical cancer elimination by 2030. Let's have a brief background. We know that cervical cancer is the second most common cancer among women in Nigeria. It's second to breast cancer, and almost 12 to 14,000 of women are affected by it every year annually. And out of these, almost 8,000 will die of the disease. So Nigeria just introduced HPV vaccine in 2023, that's around 2-3 years ago. And then now the problem of access is actually not the major problem in Nigeria. But now the issue is that even with the availability of the HPV vaccine, the uptake is still low. So this is really a main issue. Next slide, please. So our target for this learning series are the religious leaders, mainly pastors and imams. Why are we targeting them for this learning series is that in Nigeria, more than 95% of people in Nigeria claim to be religious. They either belong to the Muslim or Christian faith. And then about more than 80% of people interviewed from one of the research showed that people listen to their pastors and imams. So they are great influencers within the society. And if we leverage on them, meaning the uptake of health interventions, we can increase uptake of health intervention. So that's why we chose religious leaders to be one of our target population that we will use and leverage on them so that if they are informed, we can have the increase and then uptake in HPV vaccination. Next slide, please. So the real behavioral barrier is lack of clear, accessible, confidence-building information for religious leaders. So during this learning series, when we interacted with the religious leaders, the main issue is not that they don't actually want to advocate or they don't want to encourage people to get the HPV vaccines. The main issue we discovered was that they even lack the information. Some of them, among the interviews we conducted, have never heard of what human papilloma virus is. They've never heard of cervical cancer. So, meaning all the questions we asked after the first one were not answered. Because when we asked you, tell the people in your congregations to take their children for HPV vaccination, the person said he has never had. So the next thing, do you think there are side effects or anything? That particular religious leader did not answer a single question because he said, if I don't know what the HPV vaccine, how do you expect me to tell them? And then at the end of the interviews, actually, most of them were happy with the interviews and were advocating that if you people come to talk to us, if you come and teach us about these HPV vaccines, of course, it's a good thing. Vaccination, we know vaccination is to prevent diseases. Of course, we'll be able to tell our people and then they can get access to it. So the main issue identified during this was the lack the information. So they don't have the confidence to talk to their congregation. This picture that I put is actually not from Nigeria. I got it from online. The father and the reverend here are from Nairobi, and even the other sheikh too is from Nairobi. It's during an interfaith meeting, and the father in the picture actually gave a story of how he normally visits the teaching hospital to greet patients, and then he discovered that there's this patient that is always in pain and the patient looks cachectic and then there's an issue. So he was asking, what's wrong with this patient? And they said the patient has advanced CA cervix. And then after a while, the patient died. So it really affected him. And then after that, whenever he goes to the hospital, he will always see a lot of patients that will be with advanced CA cervix. So he asked, what is this CA cervix? And he learned that it's from human papilloma virus and all the other issues. So it was from that he, on his own, decided to be an advocate and decide to teach his people about human papilloma virus, about cervical cancer prevention, and also this is what we are leveraging on. Even if they don't come, we want to follow them because they are always in contact with the general population, either on a weekly basis or daily basis, not the way people come and meet the healthcare providers. Next slide, please. So what are the solutions? So the solution is to develop a simple fit-aligned HPV vaccine information and training for religious leaders. And then our aim is to support them with ready-made messages, reminders, and collaboration with health authorities to boost their confidence. So once we are able to train them, we tell them and inform them about the information about the HPV vaccines, about cervical cancer. We give them written either as pamphlets, then we encourage them either to say it in the daily sermons or in the weekly sermons, and then to always remind the congregations. And then once they have that confidence of talking to people, since they have the information, we think it will go a long way. And then we'll use the influential religious champions and co-branded communication materials to help leaders actively promote HPV vaccination in their congregations. We already know that these people are leaders in their own field and they are able to talk to their people. So we won't just go and coerce them to say, this is what you are going to say. Our plan is to sit down together with them, know how to frame it, know how to present the language that is acceptable to the community, so that once we produce these materials, it will be accepted, and then it will be accepted by all, because since we are we are developing it together, then it will be more acceptable to them. Next slide, please. So the potential partners that we want to use for our work is that we want to use the religious leaders. Even within the health sector, we also have our own religious societies within the institution. So if we have the Islamic Medical Association, of course, we have the Christian Medical Association, Primary Healthcare Development Board. The Primary Healthcare Development Board currently is the board that is in charge of all the vaccines. And currently, all our PHCs in Nigeria have the vaccines available, but people don't go there to get them. So by the time we liaise with them, we make sure it's always available. We'll be able to tell people where to get these vaccines. And then the World Health Organization. The World Health Organization is also a partner that is helping with all the sensitizations and all the training. So we want to partner with them so that by the time we sit down and arrange the training, the religious leaders will know that of course, we have the backing of the WHO, we have the backing of the government, and we are also part of them because we are part of the association within them. In mosque, in churches, we have doctors, and the doctors are made head of a committee within the church. So it's not as if we are bringing somebody from outside, so that it should be more acceptable to them. Next slide, please. So the lessons we learned a lot of things from this learning series. We discovered that there are lots of deficiencies and limitation on knowledge of HPV and cervical cancer. Our religious leaders are actually very trusted and underutilized group because these are people that are always in contact with the general population, and then we are missing it. We are not involving them in activities. So we've learned that is good, and we should involve them because by leveraging on them, we can increase the uptake of the health services. And then, most importantly, they are actually willing to accept it. They said once they have the right information, why not? Is it not for the good of their own people? Once we come and inform them, of course, they are willing to disseminate the information and remind the people that are under them about it. Next slide, please. So the next step is to begin to talk and educate religious leaders on the importance of HPV vaccination and prevention of cervical cancer. And then once we have, of course, funding, we like to organize trainings for religious leaders where we co-create these messages that we want them to use. And then we want to collaborate with government or other civil society organizations in organizing programs and on enlightening religious leaders and the populace on the prevention of cervical cancer. Below is our contacts. Next slide, please. So that's the last slide, but this picture is just to show one of the outreaches that we've done. This is in collaboration with the Islamic Medical Association, the Christian Medical Association. You can see behind Dr. Ishaq, who is also from another civil society organization. He is also part of this learning series. He came all the way from Abuja to join us in Jos, just to collaborate and talk to people. Thank you very much.
Thank you so much, Dr. Ali. Very insightful presentation, and a few things that you mentioned, that access is not an issue, but uptake remains low, a situation that we can all relate to as we are working within our countries on trying to increase HPV vaccination. So thanks again. We look forward to asking you more questions in the session, in the Q&A session. Our next presenter is Ms. Gloria Abiu, CEO of Glory Hill Women Empowerment. Gloria is a finance professional, social entrepreneur, and women's health advocate, as well as the founder and CEO of Glory Hill Women Empowerment Foundation. She is passionate about advancing women's well-being through education, advocacy, and community outreach with a strong focus on preventive health initiative. Through her work, she champions awareness and uptake of HPV vaccine as a critical step in preventing cervical cancer and safeguarding the health of women and girls. Over to you, Gloria.
Thank you very much. Thank you, the CCA team and everybody on the call. Today, I'm going to present on strengthening parental confidence and increasing HPV vaccine uptake in Ghana through behavioral insights. Next, please. Yes, so when you look at this picture, this is our Vice Health Minister trying to take a shot of the HPV vaccine that was just introduced in Ghana last year, October, precisely October 7th. So when it was announced that we were going to start the HPV vaccination for girls aged 9 to 14 years, it came with a lot of misconception and misinformation about the whole exercise, especially among parents of girls aged 9 to 14 in Ghana. So the public health problem we're addressing here is the high level of misconception and misinformation about the HPV vaccine among parents of girls 9 to 14 in Ghana. Next, please. So we realize that parents do not want their girls aged 9 to 14 to take the HPV vaccine in Ghana. And that is the behavioral problem that we have identified. And what we want to do is to help them allow their doctors aged 9 to 14 years take the HPV vaccine. Next slide, please. While we went through the our case study, and then we have to ask questions and take data from our target population, we realize that a lot of parents find HPV communication materials too complex and also full of jargons, which leads to confusion and hesitation. Sometimes also it's just the language barrier because most of them don't have it interpreted in their local languages. So they were not really understanding the reason for the HPV vaccine, what was it about, and all those things. And we realized that a lot of those parents believe that because some of the parents in their community are not vaccinating their girls, they have also taken that position that, okay, so far as my neighbor is not doing it because of their reasons, I will not also do it. And this has really created a negative social norm in the community. And also a lot of people started talking about COVID vaccine and other vaccines that their children had some reactions in school after the vaccination and other things. And that really created fear. And it led to a lot of emotional avoidance and panic among the parents. Next slide, please. So, start going through all those phases. We came together as a team and then provided some solutions. One of the things that we did was to identify some of the schools and then clinics, churches, and mosques that we, myself and my team, going there to actually bring the message that the government has put in a simplified and highly visual format, in fact, in their local languages, so that at the end of the day, when they hear the message, they were asking a lot of questions. In fact, I remember after one of these encounters, one of the ladies came to me and told me that she has heard a lot of misinformation on the radio concerning the vaccine. And I told her that all those things are not the right thing, and we have to simplify everything for her. And she told me that where will she send her daughter to get vaccinated? And I think the following day she was able to vaccinate her daughter. And I think we had a lot of cases like that. And the picture is one of the churches that we visited. So we also involve some of the teachers, the nurses, also mothers group and other things. I mean, other groups that we could see parents. And then let them explain this message in simple terms and openly endorse the safety of the HPV vaccine, because a lot of them were concerned about the safety. So we have to let all these people endorse it, and also use images of local parents and girls smiling after vaccination. Next slide, please. So our key partners in all these the regional health directorates, because one thing is that to be able to get access to the hospitals and other things is easier to fall on the regional health directorate so that they can lead us in accessing those particular health facilities, especially the ones in the rural areas, because we realize that most of the places that they are not able to get that information are the rural areas, because most of them don't understand English. They have to be translated into their local languages. And the pastors and imams, we have to fall on them so that they can allow us talk to their congregation. And also educational regional directorates. Without they leading us to the schools, it becomes very difficult to just walk in the schools to let them know that this is what we want to do. So we work hand in hand with the educational regional directorates to lead us in those schools that we are going to talk to the parents. Mostly they have parents and teachers meetings. So we make sure that we get those days that we can meet the parents and then talk to them. Next slide, please. So, in fact, the learning series has been a great eye-opener for myself and my entire team. After going through all these things, interviewing the parents and other things, we now realize the weight of the problem that we have at hand, because a lot of parents were just misinformed. they were overwhelmed with the technicality, the medical jargons, and high health literacy in the HPV vaccine materials. We wouldn't have known all this if not because of the learning series that has really helped us in getting through all this. And also, parents' decisions are shaped heavily by perceived social norms. We didn't know that first. So we didn't know that maybe somebody's action could really, really affect the other people that, oh, because my neighbor is not sending the child, so why should I also send it? But this learning series opened our eyes and then we're able to get that. Also, the fear from past vaccine experiences being a strong emotional barrier to parents. I think that's also a great lesson that we've learned from the series. Next slide, please. So, what next for Global Women Empowerment Foundation? I think we've been in this cervical cancer prevention program for about 8 years now. And this learning series has really added more insight into whatever we were doing. So, what we want to do now is to integrate the behavioral insights, all that we've learned from the learning series, into our existing programs and materials, and also strengthen our community outreach by embedding social norms and strategies. So we also want to strengthen partnership with trusted community messengers because they are more closer to the community and they know their languages and how they'll be able to convince them. And also share this insight with stakeholders and collaborators for them to also buy into our vision concerning the HPV vaccine uptake in Ghana. Also, seek funding to implement and scale this improved design. I think funding has always been a huge problem for us because we are able to just have internal way of getting funding to implement all these things without getting grants from outside. And also, we want to enhance and monitoring and evaluation using these behavioral indicators that we learned through the series. Next slide, please. So these are our contacts. You can join us through this. Thank you very much.
Thank you, Gloria. What a great presentations and insights, misinformation among parents of 9 to 14-year-old girls, something that we all can relate to. I kind of picked up social norms are critical. And then, of course, clear and simple messaging is the key. Thank you so much. Look forward to hearing more in the Q&A session. Our next presenter is Ms. Amelia Hamack. Amelia graduated from Harvard College with a major in statistics and a minor in global health and health policy. She's passionate about advancing health equity and housing justice through direct service, evidence-based interventions, and advocacy. At Partners in Andean Community Health, she collaborates with local healthcare providers and community stakeholders in Ecuador on women's health initiative, including cervical cancer screening, brigades, and well-being programs for adolescent mothers. Over to you, Amelia.
Thank you, Minu, and thank you to everybody at the CCAE team. My name is Amelia, and I'm here on behalf of Partners for Andean Community Health. I'm excited to talk to you all about a project we designed through this learning series called Padres Unidos contra el VPH y los Cánceres. This will be a school-based initiative. Next slide, please. Thank you. So to give you guys a bit of context, my organization is based in the Chimborazo province of Ecuador. You see it on the left here highlighted. And we do health outreach to various rural and remote communities. And last year, we started a new focus on cervical cancer prevention, offering free cervical cancer screenings during our brigades. We did this because national statistics show that cervical cancer is the second leading cause of cancer-related mortality among Ecuadorian women. And we also saw during our own brigades that of all the women we screened, over 42% of them had precancerous cervical lesions, which is very high. This really demonstrated to us that we need to be lowering these cervical cancer rates, not just through cervical cancer screening, but also through HPV vaccination. Next. Now, in Ecuador, HPV vaccination rates are below target. even though Ecuador introduced the two-dose vaccine to the National Immunization Plan in 2014. So in theory, all girls who are 9 to 11 years old since 2014 should be eligible for this vaccine and should be provided it free of charge. This is done either through school-based campaigns where the Ministry of Public Health goes to every public and private school at least one day per year offering all the NIP vaccines for the girls whose parents have authorized them to get vaccinated, or as well in public health centers. So if you're in an eligible age, you can go to a public health center and get any NIP vaccine for free. Despite this, in 2024, the first dose coverage among girls was 61.8%, which is still low, leaving a lot of room for improvement. Moreover, we've seen that research shows rates are even lower in rural and indigenous areas, such as the ones we work in. So we've been very motivated to take part in this learning series to try to lower these cervical cancer rates by promoting the HPV vaccine here in Ecuador. Next slide, please. During the learning series, I was able to talk to many parents, teachers, doctors at private and public facilities. And what I learned is that the key behavioral problem leading to this gap is that parents in the province are not ensuring their children get the free HPV vaccine while they're still eligible. Just last year, there was a change in these eligibility requirements. So it's no longer girls from 9 to 11 years old. It's only 9-year-olds, so a more stringent age, but it's girls and boys. So this change could cause confusion and people missing their chance. Next, please. And what we really believe is that people should get this vaccine through existing campaigns at schools or at public health centers, especially considering that once a child is 10 years old now, their parents would have to pay out of pocket for this vaccine. So it's important they get it while they're still eligible. Next. Once we identified our behavioral problem, I was able to interview many parents about their experiences and their knowledge about the vaccine, and a couple themes arose. First, many of the parents didn't know about the virus or the vaccine's benefits. A lot of parents had heard about HPV before, but they didn't know what caused it, how it's transmitted, and the vast majority did not know that it could lead to HPV-related cancers. Second, they didn't know about the new and specific eligibility rules, especially given the recent change. I talked to parents who thought it was a vaccine for babies, for older women, or that it was a vaccine that had been untested for boys, not approved for boys. And so this is something that we really want to address and target. And then finally, if parents were not able to bring their kids to school on the day of the vaccine brigade, they might face logistical challenges getting to a public health center, especially in the more remote areas. And this could be exacerbated by not knowing which public health centers are nearby or their hours, which ones offer vaccines, and all of that. Next. So when thinking through our solution, we wanted to make sure we were maximizing the National Immunization Plan already in place. And so we decided to do outreach at 20 targeted schools in the Chimborazo province. First step in this is to be identifying a program champion at each school. So this will be a teacher or administrator who will help us do outreach to the parents, coordinate with the teachers of 9-year-old children at the school, and they'll help us with data collection as well throughout the project. Next, at each of these schools, we're going to host an informational talk for parents. This will be proactive towards the beginning of a school year or beginning of a semester, especially given that many schools do not know when their vaccine day will happen until the week before. And so at each of these talks, we're going to really emphasize that HPV vaccination is cancer prevention. We're going to bring doctors from our partner hospital and a translator for Quechua, because in many of these places, Quechua is a primary language as well. And we're going to share videos of teachers, of parents of 9-year-olds, of doctors, and of people who are survivors of HPV-related cancers, both male and female, talking about the importance of this vaccination. Towards the end, we're going to invite the parents who attended to sign a non-binding commitment pledge that they will vaccinate their child when the vaccine day does come. Again, this is fully their choice. It's not formal, but it is an opportunity to show change in learning and to cement a change in behavior for the future. And then in addition, for each of these schools, we're going to equip them with a suite of behavioral science materials. So this will include an info sheet that we design, that teachers will send along with each of the authorization forms. So when parents are asked, will you vaccinate your kid for HPV? They are also given information about what HPV is and the safety of the vaccine. We're going to send parents pre-vaccination day checklists as well, detailing the steps they should take, such as reading about the importance of HPV vaccination, signing the eligibility form, and making a plan if their child cannot go to that day of school. We'll make eligibility flowcharts to be sent in WhatsApp groups and posted at schools, write some pre-written messages for teachers, especially ones informing parents. By the way, if you say no to vaccinating your child now, you might have to pay later on. And then finally, a template to plan vaccine makeup days. So this will include the locations of nearby public health centers, their addresses, hours, and contact information. Next slide. To do this, we are lucky to work with some amazing partners, namely Hospital Fee Busbam and its foundation. This is a hospital we've been partnered with for over 10 years, and they will help us not only with the recruitment of schools, but they will also attend each of our informational sessions, providing either a nurse or a doctor to come. And many of their staff also speak Quechua, and they're trusted members of the community. So this is a partnership we're grateful to have. In next steps, we'll have to partner with the Ministry of Education to sign an official agreement allowing us to work at schools. And then key to our program will be these program champions at each school. Next slide. In general, this has been a great experience. We've learned so much along the way. Some key takeaways for us is that information provided to parents about HPV varies widely school by school. And so our hope is to standardize some of this information. Also, most interviewed parents had limited awareness of HPV as public health organizations, CSOs that work in this field. It can be easy to think, oh, everybody knows what we know. HPV can cause cervical cancer, but this was a great affirmation that it's incumbent on us to spread the word, share this out. But I also do have a lot of hope that the behavioral science tools that we learned throughout this process can strengthen Ecuador's existing national immunization plan. Because like was explained in the previous presentation, access can be there, but uptake is a different question and different story. I'm also excited to use these resources that the CCAE Learning Series exposes to, and this will be great helps in designing our behavioral science tools as well. Next slide. So our key next steps, first is to secure funding for this project plan. Very grateful to CCAE for nominating us for a small grant. This is going to make the world of difference in this project. Once we get that, we'll be able to start developing our behavioral science, IEC materials. We'll integrate that into our current work with Patch and Hospital Fee Busbam, but we're excited to begin establishing agreements with school districts to get this project launched in 2026. Next slide. If you want to learn more about our organization, feel free to check our websites or our socials, or about this project in particular. I'm always contactable at this email here. Thank you guys so much.
Thank you, Amelia. Again, sort of the theme continues. Free vaccine does not mean high coverage. Access and uptake are very different issues. While we are addressing the issue of access, uptake has to be very closely monitored and addressed. Parents and caregivers continue to face many barriers, which can be addressed through simple tools that are designed with insights from behavioral science. Thank you, Amelia. Our next presenter is Dr. Kelechi Waugh-Robinson. Dr. Waugh-Robinson is a sociologist, public health researcher, and implementation scientist with a focus on maternal and adolescent reproductive health and youth mental health in low and middle income settings. She's a research fellow at the Ivan Research Institute in Nigeria. Through her past projects, she is advancing practical evidence-based strategies to strengthen cervical cancer prevention and care among underserved populations. Over to you, Dr. Waugh-Robinson.
Thank you very much. Good morning, good afternoon, good evening from wherever you're joining today. Our project topic is using behavioral science to increase HPV vaccine uptake in Nigeria, engaging health journalists to support cervical cancer elimination. Next slide, please. In October 2023, Nigeria introduced the HPV vaccine into its national immunization program. Despite that, the rollout, HPV vaccine uptake remains below national targets, and this is due to gaps in awareness and demands. After the 2023, there has not been another national rollout, and awareness is dropping, and subsequently uptake is dropping as well. Next slide. The behavioral problem we identified is that health journalists provide limited media coverage of the HPV vaccination, and this is reducing public awareness and demand for the vaccine. And we want them to give adequate media coverage for HPV vaccination in order to increase awareness and subsequent uptake. During the learning series, we went to the field and we interviewed our target population. And one of the questions we asked them was how they got information about health. And majority of them said they got their information from TV, radio, and social media. And being that they get their health information from this media, it's important that health journalists come into play to provide this awareness for this population. Also asking them if they've seen messages from the TV, radio, and social media. Majority of them said they hadn't even heard anything about it from this media. So that's gave us the reason that this is an important population to target and change their behavior in order to increase awareness and also increase uptake of the HPV vaccine. Next slide. Now, one of the barriers we discovered is that there is limited knowledge of the HPV vaccination and cervical cancer prevention. We asked them about if they knew anything about HPV. They didn't know if they knew anything about the vaccine, cervical cancer. They said many of them said they were hearing it for the first time. And we also found out that these health journalists are supposed to put out these messages. They are not doing so because they lack the evidence-based skill to put out this health messaging out there for the population to get access to it in order to get themselves informed. And we also found out that because the media houses as well as social media platform are interested in traction and what is trendy, what is the news that is trending, because they want traction to their pages or to their media houses or increasing followership. So because it's not so much of a topic that is talked about, they don't see it as a priority point to focus on to get traction or even increase followership. Next slide. So we designed a solution, a training for health journalists that is focused on using HPV messaging that is evidence-based, tracking behavioral insight, as well as following through practical strategies that will enable us increase accurate and sustained media coverage for the HPV vaccination. In Nigeria has 6 geopolitical zones, and we are going to be picking journalists from each of the geopolitical zones and training them using evidence-based messaging to train them on how to spread the news about the HPV vaccination. And we're also going to, by so doing, make them champions, send them back to their regions to spread the word among their peers of health journalists. And we're also going to do that by also following up with them, looking at what they are posting. And because we have social media where people can interact with posts, we can see what people are commenting, what people are asking about, what people's concern are about, and we can begin to tweak strategies based on the responses that we are getting from the work that these trained health journalists are going to be putting out there. Next slide. So we plan to engage with the National Union of Journalists. This is an umbrella body that covers every practicing journalist in Nigeria, including the health journalists. So we intend to partner with them so that we can have them send us journalists for training who are going to go back to become champions of the HPV vaccination messaging. And we're also going to be partnering with experts in the cervical cancer field why we want to do this is to help in framing messages that are technically related to the HPV vaccination. So the journalists are doing the communication side, the health experts are framing on the health side, so that we can have a package that is communication friendly as well as culture friendly for the population that we are dealing with. Next slide. So we learned a lot, being part of the learning series. We found out that a few health journalists are spreading the news about the HPV vaccine, which is resulting in low coverage and resulting in low awareness and subsequently resulting in low uptake of the HPV vaccine. So we learned from the field that a lot of people get their health information from sources, media that is totally dependent on the health journalists spreading the news. So if the health journalists don't spread the news, these people will not get the information that will make them take action to take the vaccine for their girls. And we also found that there's a capacity gap. Even if these journalists want to do that, they don't have the requisite knowledge to pass this information using evidence-based messaging structures and strategies. And we also found out that a strengthening health journalist is very key, as it's going to create a demand generation for the HPV vaccination. So if health journalists are trained and they are putting out the message, people will get aware because people are looking out for their health information from them. And when they get aware, they can now begin to take action to vaccinate their girls. Next slide. So we intend to expand training to a larger network of health journalists, strengthening our partnership with media houses as well as the National Union of Journalists chapters around the country. Continue to train them and making more champions among health journalists who would go back and spread the news among their peers. And by so doing, we'll begin to get the topic trending, and other journalists will want to get into the trend of spreading the news because they want traction in their pages and their platforms as well. Then we also intend seeking funding to support the scale up and evaluation of the impact on media coverage and the vaccine uptake with our project. Next slide, please. So these websites and other email and socials in case you want to contact us. Thank you so much for listening.
Thank you very much, Dr. Robinson. Again, health journalists are key resources or key source of information in many communities. Thank you. I'm sure this is something that a lot of us can relate to and look forward to hearing more or asking more on how you're going about that process. So thanks again. Wonderful presentations. I'm now going to invite our presenters back for a Q&A session. Again, early on, and as I was talking to you about the series, and I had said the cohort actually identified and worked with 7 audiences during the thing. And I'm sure you noticed our presenters today really touched on 4 out of those 7 target audiences. We talked about teachers, religious leaders, journalists, and parents. So looking forward to sort of learning more. Let me just see if we get all our presenters back on the screen. So I'm going to give a minute. So let me start out with you, Dr. Ali, if that's okay with you. Let me put the first question to you. Again, many CSOs have identified religious leaders as influencers of decision making in their communities. What advice would you give to your peer CSOs who are just getting started? And I think I'll follow up with a second question. So let me pause here.
Okay, thank you very much for the question. Yes, for those that are just coming up, I think they should put it early in their plan to involve them up initio. even before they get it into their national immunization program, they should involve the religious leaders, because these religious leaders are really trusted messengers. You can do all the advocacy, everything, and then they will just go one day and announce something, and then everybody will not come for that vaccination. So once you get their buy-in, because how many times do people go to the hospital? It's just when you are sick. Sometimes people will take a whole year without being in contact with a healthcare provider, but people will always go to church or the mosque. So people are always in contact with them on a weekly basis, sometimes more than a weekly basis, sometimes every day. For Muslims, they go to mosque 5 times a day. So if they use that opportunity to talk to people, I think it will go a long way. So for people that are just starting, I think they should get them involved early.
Makes absolute sense. Recognizing who is shaping the behaviors within your community is key. And as you said, in certain communities, people are really getting in contact with religious leaders many times a day versus some other entities like a physician, as you said. Thank you. Excellent insight. So I want to ask a follow-up question to yourself or anyone here that beyond religious leaders, the other entity within a lot of communities are traditional healers. You mentioned people don't go to the hospitals, but there are traditional healers within the communities that really get engaged more, as well as any other sort of grassroots providers. How are your programs either addressing now or planning to address sort of the gap in the information or factual information, I should say, within that community of traditional healers and other entities that are providing care beyond the hospital systems?
Should I answer?
Please, I'll let you answer and then please others jump in. Thank you. Go ahead, Doctor.
Okay. I think for this HPV vaccination and cervical cancer prevention, everybody is supposed to be involved. But for this learning series, of course, we are supposed to streamline and choose a target population so that we can hit the target.
Yes.
So that's why, of course, we can't be saying I'm interviewing religious leaders, I'm interviewing traditional healers and other people, but everybody should be involved. And the way we get them involved, especially with this Cancer Awareness Month or Cancer Day, we have a lot of programs. We are always at the TV stations, radio stations. Currently, we are also organizing an outreach. So we try to get to as many people as possible. But of course, if you are organizing a research, you have to target it to that population so that at least it can be measurable. Thank you.
Great point, Dr. Ali. And I think this was something mentioned, like you have to identify our target audience and create solutions. But also you make a great point that there are many target audiences in order to create this successful. So you got to understand your community better and possibly create solutions for each. But I would like to ask anybody else if you have had any experience beyond the work of this learning series in engaging more non-traditional, the healers and other sort of the healthcare providers outside of the hospital systems.
So let me come in here. I think for HPV vaccination uptake to increase, we need strong collaboration. Wherever parents go to get help, particularly when it comes to health, it's a potential place that needs all the advocacy that we can get them to get. All right. So my opinion is that they should be brought on board, or tell them that this is what is available and it's free. Whenever people come to you, can you please tell them that there's something available for them out there and it's free? It won't cost them anything. I know that many people visit traditional healers because it's closer to them culturally, and
Yeah.
they might not charge as much as they would charge in the healthcare centers. So it's important to collaborate with them so that this message can go out. So we have seen that accessibility is not the problem, it is uptake that is the problem. So let's get the awareness out. Thank you.
Great point, Great point, Dr. Robinson. Really goes back to the point that trying to understand your community better, see where physicians or parents are seeking information, whether they are the religious leaders and if they are these other sort of healthcare providers within the community, and collaborate with each and every one of them. Um, Thank you again. Let me ask a quick question to Gloria. Gloria, I think you mentioned and highlighted that simple and clear messages are key uh, to addressing misinformation. And I know it sounds very intuitive, very simple, but in practice may not be. So I want to ask if you have any additional insights to others who are maybe just getting started looking at their materials and working through them to make it simple and clear.
Yeah, thank you very much. One of the things that we do is, first of all, we take the information that the government has sent out, the materials, and then we read it ourselves and try to understand what it is. So one thing is that most of the vocabulary, the big grammar and other things, a lot of people don't really understand it. So what we normally do is after taking that particular material, then we look at it and see, okay, some of these things can just be put in simple language, straight to the point, just with some pictures to send the same messages to the people. So we just redraft the same materials, but with just very simple, maybe one line text message, and then with pictures portraying whatever the government is trying to say. Then we go and present that. So it's very easy, straight to the point, and all the people are able to just understand it without really going to maybe take a dictionary to see this particular word, what is the meaning of it, and all those things. So I think that is it. Just take the material that is already there, simplify it in a simple English or in their vernacular languages, and then present it to them. That is how we do it.
Great points. Thank you. Simplify. Don't use big words. 1 to 2 lines. Do not make it a paragraph, and use pictures. Great points. Thank you, Gloria. Amelia, let me come to you. Have a question here on what considerations would you have regarding framing of messages surrounding HPV vaccination when designing informational talks for parents and IEC material within your context?
That's a great question, and I kind of want to bring it back to the conversation the panelists were having earlier about each community having their own health attitude and needing trusted messengers because not everybody's having regular interface with doctors. Something that this question reminds me of is a conversation I had with a parent from an Indigenous community during my interview session. And they said, well, I am in favor of the vaccine, but I know some people in my community don't think that this is a HPV affects us or that these sorts of diseases affect us. That's more of a city disease. Doesn't happen in our communities. And this could be an attitude maybe because of religion or just difference in lifestyles, physical separation. But something we saw when we were doing cervical cancer screenings is that there were precancerous lesions in every community. And so something we want to make sure in our message is saying this is extremely common. HPV, unfortunately, is extremely common. It could affect anybody. And not trying to say that this is only for people who are sexually active, because that can confuse parents when you're asking them to vaccinate their 9-year-olds. So really emphasize this as a long-term cancer prevention tool for everybody. So that's how we're trying to frame it in our talks.
Great. Thanks, Amelia. I think as you mentioned it, I was remembering also a behavioral bias that I see Debbie's thumbs up coming there on not happening to me or not happening in my community. So rather than realizing it's happening to all of us, it's happening in every community. So I think that bias definitely exists, and addressing that and informing it is key. Thank you. Let me come to you, Dr. Vera Robinson. You mentioned engaging with journalists, right? And recognizing that in certain communities, health journalists are the key and possibly the only source of information. Um, and that's probably true in many of our communities, including the ones that the panelists are all working in. And I want to see what would be how do you see as because now you're basically training them to learn and then write, right? So how do you go about, and what do you plan to go about, and when you train them? Um, you said you would provide information and help them get trained. So just wondering what your thoughts are in terms of what would that program look like for them to internalize and then be able to write in again clear, simple language that people can understand in the community.
Okay, thank you very much for that question. So during the learning series, we got to understand that passing out messages about the HPV vaccination is not just enough, but giving the right message that can influence action positively. So we don't want messaging that go out and it's counterproductive. So we want to train them to send out messages that help people to uptake the vaccine rather than scare them. So we want them to send messages that say it prevents cancer rather than it is sexually transmitted disease. We want them to send out messages that says the vaccine is out there and it's free, or something like your daughter's name is on a vaccine and it's out there and it's free waiting for you. So those kind of messages that makes it personalized to them, that it's available, it's accessible, and it's free and it's healthy. Something like save your child, save your daughter from cancer tomorrow. So no parent wants to have their daughter have cancer in the future. So those kind of messaging. So that's what we want to have them begin to spread out so that we can achieve that, results of increasing uptake of the vaccine.
Great point. Thank you. And as you said, no parent wants their daughter to ever have any cancer. So as we communicate to them, whether directly or through these many influencers in the community that are influencing their decision, integrating these in the small nuggets, as you mentioned, and making these messages behaviorally optimized or behaviorally designed to help them make that decision is key. So thank you, whether you do communicate it to them or through trusted messengers in your community. Thank you. Let me see if there are any other questions that we have. Let me ask a general question before to anyone or everyone here. What surprises came from following a behavioral science model or process versus what you would have assumed your solution to be? So I think through this series, one of the big things was you may think of a solution, but then optimize it using behavioral science process. I wanted to just any insight that you would share in terms of what surprised you.
So can I go?
Please.
Okay, so what surprised me coming from implementation science is we have strategies, to implement to, cause a change. So, but for a behavioral science, you have to focus on just one, and sometimes you're seeing something that has potential for you to, add to what you're doing. But behavioral science says you must zoom in, one behavior to be changed, one population to be changed, and that's really put me in a corner, and I just had to follow that, and it was quite interesting, putting all your eggs to solve the problem in one basket.
Great insight. Thank you. Agreed. Yes, one audience to focus on as you define a solution. recognizing that, yes, you will probably have to address many audiences within your program, but solution design focus on one target audience at a time. Amelia, go ahead.
Yes, I definitely agree with Dr. Ua Robinson. That was probably the hardest part was narrowing down all of the potential things you could target through an intervention. I'd also say, just in general, something that was really hammered into me through this program was that awareness does not always lead to action. So you can't just do an informational campaign. You have to think through, how am I making it easy for my target audience to change their behavior, to do what they need to do to get vaccinated. Because everybody could know that the HPV vaccine prevents cancer, but it's a different story getting people to actually go out of their way to get the vaccine.
Great point. Knowledge is not action. We can see it in our own thing. We're knowledgeable about many things, but doesn't lead to action or the behavior that we desire. So absolutely. Thank you. Any insights, Gloria, Dr. Ali, anything else to add?
So, on my side, I think something that Debbie has always been echoing on is that um, do not continuously saying the negative things that people are saying concerning the HPV vaccine. Do not echo it just like the way they are doing it. Whenever they bring that into you, that is it. Just make sure you say the positive things. I think that has really, really, really helped me in all the things that I was doing, because the misinformation and all those things. So if you try to just solve it, but just also saying the same thing, then it's as if like you are just endorsing it. So it has really, really helped.
Makes absolute sense. Thank you, Gloria. Yes, repeating a myth, you're still restating it. So say what is a positive message versus repeating the myth. Thank you. Dr. Ali, anything else to add to that?
Yes, for me, it was really like a new thing. I'm a clinician, so we always see the patients from the clinical aspect, and then we see the pre-cervical lesions, pre-malignant lesions, and then always having patients present at advanced stage. But whenever there is a program or when it's a cancer awareness month, of course, we'll be invited to come and give a talk and talk to people, but I just realized that maybe we don't even know how to talk to people. We don't even know what to really say, because maybe the what we are saying is not changing their behaviors. So now we are beginning to learn how to talk, how to co-create with them, not to say you must do that, you must do that, because you will just finish saying it and then somebody will interpret it differently and they'll just go and give one sermon and it will cancel all the things you have said, because it's surprising. In fact, there was a time I said something, the way the people reacted, I said one day I will take that person to the hospital to go and see all the patients presenting at advanced stage. Because when I post those messages on, yeah, go and get, the girls should get HPV vaccination, if you see the number of messages that come, just to say that people still have that negative thinking about the HPV vaccine. So sometimes it's so annoying that you want to say, come, let's go to the ward and see the patients yourself. You think maybe we are lying. So the behavioral science is really teaching us a lot, maybe how to get to them, how to co-create, and then how to frame the messages. So it was really an interesting session. Thank you.
Thank you. Thank you. Definitely what everybody is echoing. What we all say matters. How we say it matters more, and how our communities digest that information matters the most. So great insights. Thank you. And one thing, let me just see if there is any additional question. Let me pose a final question. What is one piece of advice or learning from the learning series you think would be helpful to your peer CSOs who are either currently engaged in or wanting to get engaged in HPV vaccination work, trying to increase the uptake in their communities? So maybe I will start with you, Amelia, and then go to Dr. Khaliti and Gloria, and then Dr. Ali. Let me start with you, Amelia.
I would say that going through a process of designing is key, and you have to start from the beginning. You can't just think, okay, here's a solution I want to implement from the get-go and then start from there. It's important to take many steps back, really think about the problem, try to understand it, talk to more people, because a well thought out solution that's designed understanding the situation you're in, questioning your assumptions will have better results in the long run. It might just take a couple months longer.
Thank you. Dr. Kelechi.
Yes, thank you. In addition to what Amelia said, it's important to begin to shift from the clinical side because we are seeing that the vaccine is available, accessible, but why is uptake not coming? So we should begin to look at things that are outside of the clinical in order to solve the problem of uptake of the HPV vaccine. Thank you.
Great point. Thank you. Gloria.
My part, what I want to tell my fellow CSO is that in talking to people about the HPV vaccine, you can always be wrong about whatever you think yourself. Go through the process, the behavioral science process, and always go out there, ask questions to people. Don't just sit somewhere and then cook some things for yourself that, okay, maybe this is what people are thinking. Go out there, take the sample, ask them questions, and come and redesign everything that you have so that you can let it be easy for them to take whatever you are presenting to them. Thank you.
Thank you.
For me, it was really difficult deciding on the target population. In fact, initially I wrote on a different target population and I had to clean and write back that, please, I'm changing my target population because I wanted to write on all. So maybe it's good to concentrate on one target population so that we have a solution for that particular one. Because the way we took it, you have to get the target population before you start designing, before you start knowing your solutions and everything. So I think people should learn about that because if you want to do it, you can't do everything at the same time. Maybe one step at a time. For this project, we are doing this. For the next one, we can learn to interact with the next target population since all the target populations are actually important, but we can't all do them at the same time because everybody needs a targeted solution. The framing is different. The language is different. So I've learned this from the learning series. Thank you.
Great, great nuggets. Thank you. I know across the four of you, you've actually summarized the key nuggets from the learning series. So thank you. Really appreciate it. And again, thank you to each one of you. I know today is the World Cancer Day, and you probably have done many presentations in your day-to-day. I know it's evening time. The fact that you attended the session today and presented your work and shared your insight, we are truly grateful. Thank you. Before we wrap up things, I would request you to take a few seconds to give us a quick feedback on today's session. I will request again to Leah to launch the poll. And as you, Leah, go ahead, please launch the poll.
It should be launched now.
It is launched, I see it. So you should see it on your screen. Please take a few seconds to just answer this. Give your response. As many have responded or in the process, I just wanted to say thanks again for joining us. Please follow Cervical Cancer Action for Elimination on LinkedIn to learn about future events. You can add your email to the poll on the screen to be added to the email list. And before I close, I wanted to take this opportunity to share with you about a global partnership that is being launched today. by International Pediatric Association and the American Cancer Society to close the HPV vaccination gap. As part of the partnership, IPA and ACS will roll out a free online training course and ready-to-use resources for pediatric and other medical societies and healthcare workers. These tools will be officially unveiled during a global virtual event on March 4th, the HPV Awareness Day, bringing together clinical leaders and public health partners from around the world. Over the next several years, the partnership aims to train healthcare providers or aims to support healthcare providers in more than 50 countries and support medical societies in advancing national HPV vaccination efforts across its 148 members of International Pediatric Association. We invite each and every one of you to please join us on March 4th and learn more about this effort and, of course, be part of this global movement. Thank you again for all that you do in your communities. It has been an honor to facilitate this session today. Thanks again, and be safe.